thank you very much. I think we've had actually 4 sort of extraordinary, sort of inspiring presentations, but also just so practical, and actually you are doing it. And there's a huge number of themes coming through there. And we're going to go, do we have our information DJs here? People with, maybe I'm going to do it. I'm going to start off just to ask you something that sort of came through, I think, all of them, and that's about, if you like, training the trainers, or what do you do with the older generation? Because I certainly know a project I was involved with, which was trying to get the curriculums to take out the word audit, because it's so boring, and putting in quality improvement. And it started off with a trainee presented a quality improvement project at their assessment, and they were almost about to be failed because they hadn't done an audit. So, and the doctors in training, the residents, started a program, and then they realised that the trainers didn't know really how to train, or were a bit scared about it all, and had to start some training for the trainers. Just wondered if you'd each individually like to comment on how you manage, cope with, involve, train the older generation, for whom this is possibly a bit scary and a bit new. And who would like to start with that?
Thanks. We have run a similar programme over the last 4 years to David's programme, I think, where we have encouraged consultants to train in quality improvement and do that in an experiential way by taking through a project and supporting their learning. The other thing that we've noticed as a Quality Improvement Directorate is if you put 4 consultants after the name of the course, your consultant attendance increases. So we run quality improvement for consultants, which is exactly the same as the quality improvement course we run for everybody else. And advanced often helps. So advanced measurement also appears to increase attendance, but we've involved consultants. So we have a collection now of people who are QI friendly.
I think you're learning all sorts of tricks today, and they're really good ones. David. Actually, David, you're sort of the older group. You obviously have turned and have come in, but it is an interesting problem. It is
I'm only a teenager, really. No, we've decided to target we have a Northern Ireland Medical and Dental Training Agency, which is the body that look after junior doctors, and we've involved them, and we got one of their directors to help do some of the projects. So that meant that she was bought into it. And then we sent some of our projects from our course they have a regional audit competition, and one of our quality improvement projects won it using our methodology, and that has now opened the floodgate. And everyone, the other thing is the colleges have now come out and said that quality improvement work is of good value, and because that carrot is there, people are now wanting to use the new methodology. And we also have changed our language where we try not to use audit when it isn't really audit.
Okay, thank you. Kat or Jessica, I mean, from say, do you say about sort of institutions not necessarily sort of valuing it, sort of?
Yeah. No, that is a challenge, and it's a good point to raise, Fiona. We have this network of maybe 13,000 faculty who are involved, and it certainly helps that the modules are free to faculty as well as students, but it remains a challenge. It's a challenge to have just-in-time training to keep them involved. We have this faculty interest group, which we try to support on the web with resources, evaluation tools, project opportunities, but it's something that we are putting more and more attention on the Institute for Healthcare Improvement as well. So.
I think we did I didn't really talk about it that much, but when we started running our project, we already ran a course in the deanery called Clinical Leadership for the Educational Supervisor, which didn't have a very good take-up by primary care trainers. So what we did was, I rewrote the afternoon session to be about quality improvement instead of leadership, and then B, we used the small amount of money that we did have to offer backfill pay for GPs. I don't know if your experience of working with primary care physicians are, but often, I can't leave my practice, I can't leave my patients is a key thing. So actually, instead of paying for the course, we said, look, we'll pay a locum to cover your practice. And actually, we did have a very high take-up. We got a good 100 or so of the 660 trainers through. And then with the programme directors, it was really by stealth. So by going out to their schemes, a lot of them then emailed us afterwards and say, oh, actually that was really good for the trainees, please can you come to my trainer's workshop? And so that it was more organic than planned.
Okay, thanks very much. First question from the floor, Michael.
I'm Michael Bergstrom. I'm a pediatrician and a change agent from Sweden. Getting this kind of knowledge into education is a change project, and there is a lot to learn from making that change. And I want to know if you are applying the ideas of quality improvement in your efforts to try to get this into education.
Well, that's why I presented it as aims, what we did, the methods, and then showed you the measurements. So we do measure outcomes from our education, from our programme, so that we make sure that we are actually having an outcome, because if we were not, we then need to change it.
Yeah, and I think definitely for us it was well, we could spend a long time thinking about this, but we're all in post for a short time and we'd rather just get on and do. So we didn't do much planning, we did lots of doing, and then we have got quite a lot of evaluation data. I'm not really a facts and figures person, so I didn't put it on the slides today. So I think, yes, it is a process of continuous cycling and improving and working out what's going well and what's not going well.
When we launched the practicum this past year, we did 2 cycles of testing it, and have then followed that up with launching it, but still are looking at what we're doing and how we can improve it. It's interesting because what our goal is for there to be a learning, not necessarily a sustained improvement in care. Of course, it's welcomed, but again, our goal is educational outcomes. So, assessment it continues to be something that we are thinking about, and the ultimate goal of improving patient care stays in our mind.
For the 3 junior doctors involved in setting up Tickle, it's a quality improvement project. So how do you get lots of people in a room for a patient safety forum? How do you deliver teaching? Is it a generic thing? Should it be based on a serious incident or something that they've been involved with? Do you need to help them? What level of support do you provide? Would people come to drop-in sessions? So they PDSA all the time.
Question over there, and then we'll get a couple of tweety questions after that.
Hi, I'm Kate Pride from Southampton. I'm also a paediatrician. 2 things really. Firstly, I think we've heard lots about the lack of, well, we haven't heard lots, but I'm interested how you get your trainees the time. So monthly learning sets. I've been involved in some of the quality improvement projects that have been referred to in Wessex. I think getting mainstream training to our trainees, time is just one of the things. And then secondly, leading on from that, how are we going to get our colleges to move from audit to quality improvement? And we're working in that in paediatrics, but I don't know what people from other specialities experience there is. Thanks.
With regards to the first question, I would agree it's very difficult. With our very junior trainees, they have a session called Lessons Learned, where they discuss an incident that they've been involved with in a protected environment. And what they asked is, could they tag? They do that for an hour and a half, but they have 3 hours of protected time for teaching. Could they put their QI into that hour and a half? Because it seems like a sensible time to actually go, well, I found this awful thing, how would I make that into a change? With regards to the Patient Safety Forum, they have it in the evening. And I think that's about being self-directed. If I said come to an evening session, they wouldn't do anything. But they run it for them with their friends. The Royal College of Physicians is moving. We've had a programme of moving towards quality improvement. It's been piloted. It was piloted, one of the ways it was piloted in North West Deanery with core medical trainees, and that's now being rolled out, and they're appointing facilitators to help with that programme to train educational supervisors in facilitating quality improvement projects rather than audit, and it's an acceptable thing now to have at ALCP in medicine.
I mean, there's an overall point, isn't there? I mean, we're very good at training individual healthcare professionals to look after individual people. That's what we do. What we fail to do, it seems, is to train them to look after the system of care. And it seems to me that the time out actually is very valuable. If you don't take that time out to look at the system, then actually it's going to be more difficult looking after the individual patient. So there's a huge bit of learning, again, coming back to the people that write. I can't believe that. Health and safety at the same time. I mean, that's almost is a sort of an illustration of the lack of understanding at a senior level. David?
I was just going to say, I think we all have a responsibility to influence where we can, because we're all involved in our own professional bodies, and the principle of control what you can, influence what you can't, and that's all we can do is chip away. And I think the tide is turning anyway.
Well, I get the feeling, you talk about chipping away, I think you've done a bit more than chipping away, is what I'm hearing from what you've said. And here's one, just a tweety question, I'll come over there, to Catt. Did you encounter many who didn't think QI should be part of mandatory training?
In terms of training, I suppose I can't ask. I suppose in terms of trainees or programme directors, I suppose is my question. We certainly had a lot of fear from trainees, a lot of fear that they would not be supported or that they weren't able or powerful enough to do it. So I think that's where the peer-to-peer stuff was really important to address that. And you know, just like patient stories are so powerful for teaching change, our own stories and saying, well, look, I did this and I did that, and I think that was really helpful. Programme directors and trainers very much, isn't this just Audits rebranded? Which in some ways you can argue it's just really good quality audit. But actually, I think they did come around quite quickly when we talked to them about how that can make a difference to their practice. So they know that registrars have got a bit more protected time than they have, a bit less pressure, and that they thought, actually, I could really see my registrar doing something transformational for my own patients. So I think that was the key way that we tried to get them on board.
And Jessica, one for you was, did the open school success stories, were they shared with all the other chapters? That's one of the tweety questions.
In terms of, it's a Twitter question. We do try to bring the chapters together to share the learning and harvest the learning together. We did so at the forum this year. We'll continue to do it in our face-to-face programming, but we also do this through social media. We connect with them where they're already going, Facebook and YouTube videos, and sharing best practices from the chapters on our website. So we try to harvest and share as much as possible. Yeah.
Thank you. Question.
Hi, my name's Prash. I'm in an FY2 at the moment, and I really like this slide because I think we're obviously here, quality and safety in healthcare, and the idea is to promote patient safety and things. But I'll guarantee that there's a lot of junior doctors at this conference who are literally doing that and just ticking the box. And and when you're talking about a system where there's already a load of projects going on that you can join and you can add on to, yet when you're applying for jobs, you get extra points for having created your own project, designed it yourself, then re-audited it, regardless of whether it's sustainable, regardless of whether it actually changed anything. Whereas someone who's added on to someone else's project and actually changed something and actually done something worthwhile won't have ticked a box, won't have got an extra 2 points on an application, and won't have got a job.
I think it's a very good point. It's some of the work I know that Gavin Catt's predecessor did. Whether you want to comment on that?
I think one of the things that we do is that we have a corporate project on a topic. You can design your own almost sub-project within that. So there is a broad improved delirium or dementia care, but you can look at what's going on your ward with your group of patients in your rotation and design I'm going to have this as my aim and run a project within the context of this big collaborative and present at that collaborative, but actually run a much smaller project within a 4-month period within the context of a bigger project, and that does both things.
Can I just ask, how many of you here are doctors or other healthcare professionals currently in a training programme? Hands right up. What about 15%? Something like that. Just thank you. Rob.
Question for Rob Bethune, I'm a surgical resident in the Southwest. A question for Emma. I think this is an absolutely fantastic and very sophisticated programme. We do a much less sophisticated one in the Southwest. Have you tried to spread this to other hospitals?
Sorry, say that again.
Have you tried to spread this programme to other hospitals?
Not yet. We have medical leadership, Northwest Medical Leadership School within the region. So that might be the place to do it. I think about getting it in terms of getting it embedded and working properly. But as trainees rotate between organisations, there may be opportunity to do that, but we're not there yet.
Okay. Next question.
Yeah, Ranjit Babulau. I'm another paediatrician in the audience.
Who's looking after children today? I'm beginning to worry.
My concern is our tendency to learn by serendipity. I wonder if there's a need, or it's been well articulated, framework of competencies in quality improvement and patient safety.
It's making a framework. We tend to learn by chance. Is there a framework for learning in patient safety?
Yeah. Actually, the first slide where I mentioned the IOM, the Lancet Commission report, and the World Health Organization, they've each given frameworks for competencies, and as well as the Association of Academic Medical Centers. And I'd be happy to distribute those. I'm not sure how the best way to do that is, but.
Don Berwick wrote in 1992, 20 years ago, in the BMJ, there's two really good articles about doctors and quality improvement. And he actually puts the things you've got to learn in order for quality improvement. Yeah. And I use them, I've nicked them and used them for slides for talking. Just go to PubMed or BMJ, Don Berwick, 1992. They're free because they're so old, but they're really, really good.
Hello, my name's Marion Lynch. I'm from Oxford and run the QI fellowship programme, so thanks for the plug for Oxford Deanery and Wessex Deanery. I have a question as an Associate Dean. Whilst we start to integrate QI projects into trainee programmes, we need to have a clear idea of how we assess that without disadvantaging some who actually won't want to be so involved with this. What are your thoughts on the assessment criteria for success in implementing a QI project?
I think I would reflect back on what Jessica said earlier, that when this was a big issue for us when we changed the requirements in London, and there's lots of talk about how we're going to assess them. And I think the key for us was we're not looking for success in terms of has this made a statistically significant difference to patient care. We're looking for evidence of learning, participation, and we're essentially assessing them in a mainly a formative way. So it's summative in that you have to participate, but the assessment is about having a formative interview with your supervisor or on your panel, saying, well, what did you learn? What would you do differently next time? And we do get them to structure a report, which is essentially based on Squire, similar to the forum abstract submissions. So we've gone for a very light touch assessment process, but there are lots of ways that you could approach that.
I mean, something that was hinted at in one of the sessions was about actually making doctors in training part of the organisations within which they work. In which case, once you do that, then the behaviours, and I think Jessica talked about behaviours and about culture and about attitudes, actually can then get marked, like team working, understanding critical incidents. I mean, so it seems to me it's not just here's a quality improvement, here's the assessment. Actually, that is part of a bigger change. Does that make sense to you all? That actually it's. I mean, one of the problems I see as doctors in training are your lovely slide, which I want to nick, which is the doctors outside the circle of the organisation. I mean, so in a sense, in the UK, and I'm pretty sure it's the same elsewhere, doctors in training tend to be without their organisation. They contribute hugely to it, but are not actually part of its decision making. Well, that was lovely. Your steering group's fantastic. No, I'm rushing through because there's lots of questions. Another question at the back here.
Hello, my name's Gavin Lavery from the Safety Forum in Northern Ireland. When I'm clinical, I'm an anaesthetist and an intensivist. It's a question.
Are you a weightlifter?
No, I'm not a weightlifter, unfortunately. The questions about the colleges and quality improvement versus audit. The Royal College of Anaesthetists' last audit recipe book was co-authored by Carol Paton, I think, who's an IHI fellow, and it's heavily designed, if you like, on quality improvement lines. And I'd be fairly sure that the College of Anaesthetists, at least, would recognise a good QI project as ticking the audit box, and I'm just wondering if anyone else in the room can confirm that.
Actually, I think there's been a big movement through the Academy and Royal Colleges to all the college curriculums to change the word audit and put in quality improvement, simply so there's no ambiguity. And I think the anaesthetists have done that. I mean, David, you might know more.
Yeah. Well, Gavin, I was at a meeting where the president of the college stated that they rated quality improvement projects higher than audit projects.
Yeah. I think we need to get the message out to trainees that if the only thing that's making them hesitant is this audit tick box, that's not an issue, and that we should be saying, this is easier in many ways and it's more valued.
Yeah, I think we could just do that.
Agreed.
We're just running out of time. I just want to give our fabulous four presenters just a chance to say one further thing to your audience here, and then I want us all to thank them. David, you want to just a final word to your? I
would say get involved in educating every member of your healthcare team from the porter up, and the culture will change.
I think I would say we've already heard how many fantastic educational stuff there is out there. There's so much online resource. You don't necessarily need to know all the stuff before you can teach it. You can signpost people. So just give your trainees permission and encourage them, and they will do great things and teach you along the way.
Jessica?
Yeah, I would echo what both David and Catt said in that thank you for being involved, first of all. You're integral to the success, and you are the experts in this. And to involve your trainees and to see them as helping the institution's quality improvement goals rather than it being about training them, because I think they can be leveraged.
Let them know it's important, let them know they can do it, and let them know that you're interested in what they say and what they find and what they're doing.
I think the doctors in training are the best kept secret, certainly in the NHS. Any other industry would have them. They're the most ambitious. I can say this because they can blush. They're the most ambitious, able, energetic group in any organisation. Any other industry would have them next to their chief executive or their medical or managing director. I mean, we are bonkers, actually, how we actually structure it. So, I mean, I've got a separate mission, which is to restructure, and as I love the stuff that you've all done, which is to bring people in. I'd just like to end by thanking David Catt, Jessica, and Emma very much indeed, not just for presenting, but for the work you have done, which I hope will take all of us sort of a step further forward. Thank you very much indeed.